Hello, good evening, everyone. Welcome to our third hygiene lecture series.
Third webinar already.
I know.
What are we going to do? We need to start a podcast or something. Instagram series, yes.
Well, it's been wonderful, really, with the audience and their engagement, and that's why we decided to do
more.
Exactly this topic, which is, I think, this is actually really exciting.
This is our favorite, one of our favorites.
One of our favorites. There's always questions about it, about the soft tissue recession, when to refer, what to expect. So I think this is going to be a great presentation, very interactive. We're having the Q&A session as well. So please watch this, and if you have any questions, come prepared on April 21st.
Yes, we will be in Greece. We're in Greece right now. This is the backdrop right now, but it would be nice.
Yeah, exactly. Hey, state of mind. You're there.
Yes, exactly.
Yes.
Exactly.
Anyways, welcome back for everyone who watched our first two webinars, and welcome to everyone who's joining us for the first time. If you don't know, so we are actually periodontal specialists in Fredericksburg, Virginia. Do you want to kind of tell
We have we've established practice. This practice has been in the area for about 25 years with Dr. McGrail, whom you see in your upper left part of the screen. And 6 years ago, myself and my wife, Dr. Piman, took over the practice, and we are fortunate to have grown. Our practice has grown. Dr. Aboosi is now with us for the past few months. We're very fortunate to have him. We do think ourselves as the leading periodontal and implant specialists in our area, and we are surrounded by some amazing individuals. We have an awesome team. You see some of our wonderful people here in these photographs. Couldn't do what we do without them, so we're very grateful. That's where we are. Please come and see us, 609 Jefferson Davis Highway. Perfect.
We love being a resource as well for the dental community here, so if you have any questions or anything like that, we're always here to help. We do have our website, synergy.com, and we actually just have launched a portal for our referrals and our dental colleagues. So we have different video galleries. All these recordings for the previous lectures and this one will be available as well, so you can watch them at your own convenience later in the future. And it will be an ongoing process.
Yeah, we try to stay up there with the website. So the website is serving as a resource. Feel free to log in. You'll find under the provider portal, you find a lot of information, and also it has a lot of information about us if you feel like wanting to work with us.
Very good. So now for the topic of our today's lecture, it's the issue with the soft tissue. It's actually, we're talking about recession. Not only recession, it's really the mucogingival defects around teeth, whether there's recession, exposed roots, whether there's a combination of recession and some loss of tooth structure, non-carious cervical lesions we call them, whether there's lack of attached tissue, keratinized tissue, phrenum attachment, all that. We'll try to address them in this lecture, and we'll bring also clinical cases and show you what to expect, the goals of each procedure, the different materials we can use, and all that.
And at the end, I think you've set up a nice little quiz session where you can test yourselves on, seeing the case initially, what to expect, what you would expect us to do. I think we're very capable, but we're not magicians, so we want to make sure that you know the frame in which biology allows us to operate and function. So I think the last section will be also very useful.
Exactly, and that's really a great point. We're always very careful when setting expectations for patients. What's achievable and what's not. So I think if we're all on the same page, that would be a great. So first thing first, we want to start with diagnosis. Basically, how to diagnose a gingival recession, or if there's any problems with the gum. And really, the most important thing first is to go back to anatomy and just kind of be able to identify the different components of the gum and the gingiva. So you look in this slide right here, you see where the arrow is pointing. So basically in the mouth we have two kinds of gums, the tough keratinized gingiva, and then the loose red mucosa, and the junction between them is really what we call mucogingival junction. And we also have what we call the free gingiva, which is basically the sulcus in the area, or a pocket if there's a deep pocket in that area, and then there's also attached. So basically, how do we determine the attached tissue? It's the width of the keratinized tissue right here minus the pocket or the sulcus depth. And multiple studies have shown that we do need some minimum amount of keratinized tissue or attached tissue, around teeth, especially if there's restorations. We can address that in the, later in the presentation as well. To protect, works as a barrier around teeth. I usually use the reference for patients, kind of if you're wearing a jacket and you have a sleeve, or if you're wearing pants and you have a belt there. So it's a nice barrier on the tooth structure to prevent recession, and also
so that's the role, right? The role is to create a seal against bacteria,
exactly,
and provide some support on the teeth. Unlike the role of the non-attached tissue, the red veiny, elastic, it's full of elastic fibers that you see over the mucogingival junction or below the mucogingival junction on the lower. That's the same tissue that lines inside of our lips, inside of our cheeks. And what I say to patients is, you use that when you eat, when you chew, when you talk, everything is moving. They have a different function. That's not the kind of tissue you want around your teeth. That's the kind of tissue you want around your, lips and cheeks and so on.
Exactly, kind of deflecting the food debris.
Sure.
And also part of the diagnosis and understanding the anatomy is having X-rays and radiographs, because really, as we'll see in the presentation as we go, now we're looking at not only the gingiva and the gum, but it's also really the whole periodontal complex and the bone, alveolar bone in those cases. So the interproximal bone in these cases will actually determine how much root coverage we can achieve in those situations. So basically, this is just from previous studies that were done, observational studies on humans. We can see where do we have the most keratinized tissue, ideally in humans, and we can see that there's a lot of tissue, keratinized tissue in those areas in the anterior maxilla. It does get a little thinner around the canine and premolar. Obviously, on the palate, we have abundance of that keratinized tissue, and then in the mandible. Same thing, it really gets thin around the canine and premolar area, and on the lingual side of the mandible, it gets a little skinnier or smaller.
And we see a lot of recession in the front too. So that's an area that you can see even in this photograph. That's an area where we have very thin. The width is not as much on the lower anterior.
On the keratinized tissue to begin with, exactly.
So we'll see a lot of cases about that.
And so how do we locate the mucoidal junction? Basically, the demarcating line between where the keratinized tissue is, the attached tissue, and then the loose red mucosa. So there are multiple techniques, actually. The best is really doing histology, which is not clinically applicable, obviously. There are a couple of dyes that you can actually apply. And really, it's just different histology, the elasticity of the tissues. But one technique, actually, it can be sensitive to some patients. So I wouldn't recommend it on every patient, but if a patient's tolerating it, there's definitely, you can roll the probe and see where it there is a little bit of resistance in that tissue, and there's almost like a little demarcating, like I said, line in that area. So that's how you know where your keratinized tissue starts, and then you can actually measure how much you have around those teeth. And some might have zero, so don't be surprised if that's you don't actually find that line.
So being careful, because that can be sensitive, as you said.
Exactly. Some patients can be very sensitive in that area. Now, for the diagnosis, there are different classification systems for the recession. The first one was actually by Sullivan and Atkins, and they actually wrote one of the first papers about gingival grafting. It was a free tissue graft, free gingival graft. It's pretty self-explanatory, it's pretty easy. There are four different classifications. As you can see on the screen, there's the based on either shallow or deep, and then either narrow or wide. Like I said, this classification really started for the free gingival graft. So they were, obviously whenever it's a little bit of a narrow defect, there will be some bridging between them. So you expect more coverage in that area. Same thing for the deep area as well in those areas.
So that's interesting, because, in your mind, you see all these recessions, like, whoa, that's a lot of recession. They won't be able to cover that. But in reality, the deeper the recession is, we get more blood supply from the periphery. So exactly. It's allowed us to cover more of those and get these dramatic, spectacular results. Exactly. And then we have these recessions that's kind of shallow and wide, and we fix the tissue around it, but then we cannot get that extra coverage for that 1 extra millimeter. And you're like, how can they not cover that? and it has to do with the bone anatomy, is there bone loss, and so on and so forth. But sometimes the wide and shallow recessions are harder to cover.
Exactly. Just how much space also the cells and
it's a matter of blood supply.
Beats in the middle.
Because you have like tooth surface, you got to imagine this. The more tooth surface you got exposed, the more vascular surface we've got.
Exactly.
So the less blood supply your surgeon we get, so the less easy it is to cover that.
Exactly. So the other classification system, this is the most widely used, well, at least until the new classification came out, and we'll talk about that. But the Miller classification, and really this is more of a prognostication system, I would say. So it's just basically you can classify the different defects, and then based on that classification, you can tell how much root coverage we can get. So basically, class 1, there's just recession that does not extend to the mucoidal junction, the line that we talked about locating earlier on. And there's also no interproximal attachment loss. That's either bone loss or recession. Class 2, we don't have interproximal loss, attachment loss, but the recession extends to or beyond the mucoidal junction. So that is almost like that deep the deep defect from the Sullivan Atkins. Now, in these cases, classes 1 and 2, we do expect full coverage, 100% coverage, because we do have that interproximal attachment, the bone level. And usually what I tell my patients as an analogy is, imagine two tree trunks and you're trying to put a hammock between them. You can only go as far as where the tree trunks are. So same thing with the bone level interproximally. If you have no bone loss, you can expect that you can actually get the facial coverage. But if there is interproximal bone loss, we can't really achieve full coverage in that area.
So that's why that's
the
key.
Periapical X-rays are important too.
I'm glad you said that, because many times we'll get the referral for recession. We get bite wings because that's the bite wings that we take every year, and yet we have no X-rays of the area that we're about to treat. It's hard to set expectations unless we know
exactly
what the bone levels look like. Another practical way to see it, and I think we're going to have some cases like that in the future down these presentations. If you see triangles between the teeth, and if you see the papilla is not going all the way up to the contact point, that's by definition means we cannot get 100% coverage. Exactly. Because it means the posts, the bone, is lower.
There is attachment loss, basically, interproximal. Exactly.
Yeah.
Continuing on with Miller classification, so class 3, basically we have interproximal bone loss, but it's not more than the facial, so it's less than the facial attachment loss. And also, if any tooth facially malpositioned, that's automatically considered a class 3. And then class 4, there's significant amount of interproximal bone loss. Usually, it's actually more than the facial bone loss, bone loss, excuse me. So with these cases, with Miller class 3, I think it's 60-70% coverage.
Yeah, I mean that's just numbers. I mean partial coverage.
Partial coverage. And class 4 really, it's really
don't expect any. That's what they literally tell you. Don't expect it. Now you may get some if you're lucky.
Exactly.
But we shouldn't expect any coverage.
Exactly. And some of those cases we might actually end up having some changing the gingival thickness, phenotype, but not the coverage. So they can still benefit from grafting, but not for root coverage. Now, this is one of the newer classification, the current classification from 2011. It's actually been featured in the new periodontal workshop for the classification systems. And there are three classes for this. The first type is the recession type 1, where there's gingival recession with no loss of an interproximal attachment loss. So there's basically no pockets interproximally, and there's just facial recession in those areas. Same thing, we expect good results and full coverage here. Type 2, there is attachment loss interproximally. Now, when they say attachment in this case in the chiro, I like this because they actually talk about pockets as well. Not only what you can see, the recession from the CEJ to the gingival sulcus, actually to the depth of the pocket. Yes. So some people call that hidden recession, but it's basically they tell you where the bone is. And what I also like about the chiro classification is actually prompt you to look for the CEJ, because that is very important. We'll talk about some of those cases with the altered passive eruption, because you want to see, really to set the expectation to say if we got root coverage or not, you have to know where the CEJ is, because you don't expect the root coverage to extend on the enamel, it's only on the root surface. Yes. So what I like about this is actually prompts you to look where the CEJ is and if it's identifiable. So class 2, like I said, there's interproximal attachment loss, but it is not more than the facial attachment loss. And then class 3, basically is just you have more attachment loss interproximally. It's more than the facial. And like I said, again, the attachment loss is considered from the CEJ to the depth of the pocket. So you're considering the pocket depth in these cases as well. So etiology, why does recession happen? And it's really multifactorial. I think Dr.
Yeah,
Ntounis
so I mean, imagine anything that can cause inflammation of the gingiva has the potential to cause recession. And in people that are genetically have thin gums and thin bone or thin bone, you may see more recession. Also, every time you change the position of the teeth orthodontically, if you're starting with somebody who has very thin type of tissues around their teeth, they're obviously more prone to having recession done. That doesn't mean the orthodontist did anything wrong. It just means that the environment in which they operate tends to be much riskier. So if you were to break down etiological factors, trauma from oral hygiene. Is it common? Not as common as we think. It's there. It's not as common as we think. Like the old tale, oh, you're brushing too hard, and you only have recession on only one tooth. That's kind of hard to explain, to tell the patient, oh, you're brushing too hard only on that tooth. So brushing too hard is part of the story. A lot of it has to do not only with the brush that people use or how they use the brush, but also the kind of toothpaste they use. So for example, we know that whitening toothpaste tend to be much more abrasive. So it's also that three-body wear that we're creating between the surface, the toothpaste, and the brush. So trauma from oral hygiene is real, but it cannot be just alone the story, because I can show you a lot of aggressive brushers that have thicker biotype, you never see recession or phenotype. Of course, recession is caused by plaque. Plaque will cause recession as it would cause pockets. It will cause bone loss. Eventually, as the bone sets the tone, the soft tissue will follow that. Periodontal disease, also caused by plaque. Other habits that cause gingival trauma. Somebody is chewing on their nails. Somebody is chewing on pens. Somebody is using a pipe or tobacco. Where they place where they're chewing tobacco, or they're placing the tobacco in a certain area. You see this area is full of recession, along with some tissue differentiation in that particular area. Flossing trauma, flossing clefts, where people are super good hygiene, they have super good hygiene, yet they come in and they do their own gum surgery. You see there's a rail that's been formed by the flossing. And the best way to find that out is give the patient a mirror or hold the mirror in front of the patient, get them to floss for you slowly. And you will see how they recreate the same flossing cleft, the same trauma over and over again. Flossing cleft can also be caused by proxy brasses. So it's a proxy brassing cleft. So we need to be aware of that too. If the size is not appropriate, or if the use is not appropriate, they can cause a rail in the gingiva. That will attract bacteria, and it may cause recession in that area. Removable partial dentures, I'm sure you've seen that, clasps, any appliances that we have in the mouth, even Invisalign trays. Now we're starting to see a lot of recessions from Invisalign trays. They're not trimmed properly. They're pushing gums down, chronically. So they cause that. Ortho appliances and so on. The true etiology, what it comes down to, is inflammation. Something is hurting the gums. And if the gums are not strong enough, genetically, that will cause recession. So your risk factors here are thin phenotype, movement of teeth, as we were saying, anatomical differentiations, deformities, like a high frenum pull, when you don't have enough attached tissue to begin with, where there's not enough vestibule, so there's not a lot of running room, and when the position in the arch is such that will predispose to recession. So you have this canine that's sticking out, for example, or a canine that the orthodontist pulled down with a chain after a surgical uncovery, and the whole tooth is coming out more facially. These teeth will most likely get recession, and would most likely require some kind of intervention. So these are the main types of etiologic factors. Now you had a little slide here. We're going to talk about this.
So yes, I just wanted to discuss a little bit about periodontal phenotype, because this is something that's been in the periliterature in the past couple of years, and I actually like it because they are steering away from using the word biotype, tissue biotype, because biotype actually by definition it's a group of organs that have the same genotype. So it's just basically the description of those organs, but phenotype is actually the look of an organ that is a combination of multifactorial from both genetics and environmental. Sure. So we cannot change really the biotype, we can change phenotype.
Sure.
So periodontal phenotype, we're actually these days we're looking at the soft tissue thickness, the width, how much keratinized tissue we have, and also it gets into play the bone morphology, like Dr. Ntounis was saying, sometimes, where the teeth are located in the arch, if there's really no facial bone that will, create create thinner periodontal phenotype in those.
So we like phenotype better.
We like phenotypes better.
Changing
That's
that.
the words exactly, because that's the phenotype is what we can change.
Sure,
exactly.
Super. So that's another one that actually shows. This is a very simple. Is your probe shining through somebody's gingiva? If your probe is shining through somebody's gingiva, it means that the gingiva are thin.
It's less than 0.8 millimeters.
So it's
usually
less than 1 millimeter if you see the probe through. This is an area that's
high risk.
That's high risk. So we want to make sure that if the orthodontics are considered, the orthodontist is aware of it. We want to make sure that the brushing is such that doesn't predispose and recession.
And this is from an article. Actually, I quoted the article.
If your dentist is about to prep a tooth like that, it also may mean that they cannot go sub G. If they go sub G with their prep, they will get recession, and even by placing the cord to make the impression. Okay, so the dentists are aware of all that, but it's, a lot of it you see it yourself and say, "Hey, doctor, this patient has very thin tissue." So periodontal gingiva. These are a couple of references that we know from probe visibility is associated with thinner measurements of gingival thickness, which may mean thinner bone. This is other, many times we know that missing gingival tissue may mean missing bone.
You can see the root.
Right. You can see there a fenestration. What you see there with the F, it's a fenestration. It's a little window where the bone is thin. What you see there with the D is a dehiscence or a dehiscence, where the entire buccal plate is missing or is very thin. Both of those dehiscences and fenestrations point out to the type of bone that is extremely thin. So the way we approach this now, and this is a wonderful classification by Dr. Mandelaris. I'm not going to stay on this slide too much because I want to show you this picture and you get the idea. You have individuals that have very thick type of bone, both over the root of the tooth, but also below. You have others that have a very thin top part of the bone with thicker base of the bone. You have others that have thick top and thin bottom, where you can see there's fenestrations, the roots are shining through, and of course you have the high extreme risk patients where the entire bone is missing from top of the CJ all the way down to the apex. And these are the high risk cases, because imagine that individual on the fourth photograph on your lower right that needs expensive ortho. What's going to happen? The teeth are going to get pushed out even further outside the bony housing. Remember this slide, because we will have a pretty cool case to show you as we move along. Okay, prognosis.
So prognosis of treating gingival recession is usually pretty stable. So first, we're going to stop the attachment loss, stop the recession. Like I said, whether we achieve full coverage or not, that's a different topic, but we'll stop further recession in those areas. So we're actually saving the teeth because we're stopping the attachment loss. Improve aesthetics, especially in cases in the anterior where we have root exposure, and then also reduce sensitivity. Now, this might be questionable.
Oh, I like that. Yeah, say that. Why is it questionable?
So sometimes it might actually help, especially if it's gingival sensitivity in those areas where we have, like keratinized tissue, and we give them keratinized tissue in that area. Sometimes if we have root exposure, I think it's a combination of using desensitizers and gum tissue. I just like to set my patients' expectations. So I don't want to promise that, we're going to take care of your sensitivity completely.
Yes.
Because once the roots have been exposed, sometimes it's hard to desensitize them with that.
And many times you have recession. We cover the recession 100%. The sensitivity is still there because sensitivity doesn't come from the root surface. So, long story short, covering recession will likely help sensitivity, but we do not guarantee that, because sensitivity is so multifactorial, may be coming from the crown of the tooth.
Exactly.
And that we have no control over with gum work, okay? And I think the study, now there's a systematic review that kind of showed that we cannot promise,
predictably say that we can reduce sensitivity. Absolutely.
By gum work, yeah.
And we included a couple of studies here, just long-term follow-ups on gingival grafts. This is the first one, free gingival graft. Actually, they followed them from 10 to 25 years, and they showed that actually it does. They are stable. There's no further recession.
So, and I think that'll be for a lot of our hygienists. They may not know the difference between connective tissue graft, free gingival graft. We will show all that.
Absolutely,
right, as we
the
move
difference
along.
between exactly,
and you will see how they're being done and all these things.
Exactly.
So don't be alarmed by us using the terminologies free gingival, connective tissue, and so on. We're talking about gum grafts in general at this point.
Absolutely. And this study, what I like, it's actually with split mouth. They did one side and they did not treat the other side. So they were able to compare it. And obviously the treated side, it was stable. It actually gained some tissue. We call it the creeping attachment over time. The other side where it was not treated, it actually kept receding in that area. Now, another study that we included is also long-term evaluation, 20 years from Pino Prado. It's actually about the connective tissue graft. And overall, the gum, the treatment of recession preserved long-term 20 years follow-up, and it was still actually stable.
So that's the point. These tissue grafts work. They work long-term, and they save teeth long-term. And they're stable long-term. So especially for the free gingival grafts, which you will see, the joke I make with my patients, and your restorative dentists will love that, is this is the only treatment in dentistry that you can look the patient in the eye and tell them this is going to last you forever. Because this is true. I don't know a lot of any other treatments in dentistry that you can predictably say my crown is going to last you forever, because that's likely not true.
No, but yeah, this tissue is not going anywhere.
Yes.
Once it's stabilized after 14 days, that's it. So treatment options, doctors, you want to go over?
Treatment options, we have a lot of treatment options nowadays. Still, though, it's important to mention that the gold standard is utilizing patient's own tissue, autografts, we will call those, either in the form of a connective tissue graft or in the form of free gingival graft. Very basic differentiation. Connective tissue graft is what you take from the inside of a palatal flap, which is basically the inside without taking the top layer. The free gingival grafts is where you remove the entire inside and the top layer, and you leave a little bit of periosteum.
Exactly.
Yes. So anyway, you will see the surgical techniques. You will know that's still considered the gold standard. Now that doesn't mean that every case will treat with autogenous graft because it's the gold standard. There are cases that respond very, very well with allografts, with donor tissues. What you need to know and tell your patients about donor tissues is that these are not transplants. We're not transplanting human living cells in their mouths. These are just matrices that have been taken from human donors. They either sterile completely or they have been heavily processed, and eventually they get replaced by the patient's own tissue, by the patient's cells. These are the main ones: autografts and allografts. Autografts from the same patient, allografts from the same species, different patients, so human products. There are other products that are synthetic. There are other products that come from animals. Collagen matrices and so on and so forth, porcine or bovine. Okay, not mainstream situations. Although every once in a while you see something coming in the market and it seems to be working initially. In the old days, we used to do guided tissue regeneration with membranes, like we did. We tried to reconstruct the entire PDL, periodontal ligament. Combination of the above, and then on top of the materials that we use, we also have different techniques utilizing the flaps. So we can move flaps around, we can move gums from adjacent teeth, slide them over, we can move flaps from the palate, slide it over, and do all these. Other names you may have heard most recently is a trademarked is pinhole, right? It's a trademark process by a dentist. This basically utilizes the same principles as we call vista. Vista is a vestibular incision. It creates a little access in the vestibule, and I'm not going to go into the trademark situation for legal issues. We want to avoid that. But the premise is that we establish mucosal access, and through that, with a vista technique, we feed either a connective tissue graft or an allogenic dermal matrix or other things, collagen matrix and so on. The most important surgical decision making has to do with the experience of the surgeon and with the anatomy of the area, and of course the risk factors that are involved with the patient. But we will try and kind of demonstrate a couple of those different treatment options as we move along. This is the Vista, was first introduced by Dr. Zadeh. Just always want to give credit to the people who come up with descriptions of techniques that are used, basically vestibular incision. The goals when we do these techniques, either way, are to achieve as much root coverage as possible, to basically increase the attached and the canine tissue in width this way, We want a lot of that attached tissue this way, but we also want to increase the tissue this way. Because if you were building a levee against a flat, you don't just want a tall, skinny levee. You want a barrier that's tall and wide, okay? Because it's harder for that inflammatory front to penetrate and create recession. Of course, we want to increase the vestibular depth, eliminate any frenum or any frena that are there presently.
Easier access for brushing.
Thicker tissue, so it's not as sensitive when people brush. Improve aesthetics. We want to improve tooth prognosis. If we're doing a bridge, we may want to make the site, the pontic, look better, more like a natural tooth instead of, you see a bridge from a mile away because the pontic looks like a fake tooth. Yeah. Pre-prosthetic augmentation, where, somebody wants to put a pontic in or restore an implant, we want good tissue so the area looks natural and the restorative
depth. If it's a thin phenotype and they're doing subgingival margins,
yes,
that also
we want to
can
increase,
be considered pre-prosthetic, just to
cover margins easily. And another thing that I'd like you to start thinking about is pre-orthodontic augmentation. A lot of our cases, and 90% of our peri-ortho cases are post-ortho. Wouldn't you? Is that fair to say?
I think so. Yes.
Now with SFOT things are changing, and I will get into that. But post-orthodontic. Ortho recession. Same story. Ortho recession. It's not the orthodontics did anything wrong or the orthodontics caused recession. That's not true. It's orthodontics in the environment of a very thin phenotype, risk factors, thin bone, expensive orthodontics, and so on and so forth. So pre-orthodontically, if we have a high-risk case, the orthodontist, the hygienist, the dentist can identify and recognize the case and say, hey, you know what? Before we start moving your teeth, let's fix your gums. Mm-hmm. Let's make them thicker, because this way allows the orthodontist to have a larger envelope in which they can move the teeth.
Exactly. And that's a great point about expensive orthodontics. I think that's what the modern orthodontics, instead of doing extractions, they're actually trying.
Because it helps with airway and so on. We're not orthodontists, so we're not claiming to be orthodontists, but we can help with gums. So, autografts. That's a good opportunity for you to maybe discuss a little bit about harvesting connective tissue versus free gingival.
Absolutely. So autografts, basically, like Dr. Ntounis said, it's from the same patient. We take it from the roof of the mouth, from the palate. A lot of people, whenever they hear that, they freak themselves out. They Google that. Honestly, I haven't had it done on me personally, but most people, with the way they describe it afterwards, having a pizza burn. So it's a little sensitive, maybe. It's nothing too painful that will wake you up from sleep or anything like that. Like Dr. Ntounis also mentioned, it is gold standard in treating tissue recession. Now, unfortunately, there's only limited availability. If someone has the entire lower jaw that needs grafting, we can take the whole palate tissue there. So it's mostly indicated for limited areas, or if we want to do segmental treatment, different appointments will be great. It does actually increase the zone of keratinized tissue, and it has excellent long-term results just because it's been used for a longer time than the allograft. So we actually have longer studies to support it. Now,
one main point I want to make here is once we remove that tissue, most of the time it doesn't even bleed because we want to stay, somewhat superficial. Our thickness is about 1 millimeter, maybe 1.5 millimeters. So it grows back. The patient needs to know that, and it grows back better. So
and
it's
the
not
roof
like
of the mouth has high vascularity,
yes.
So the high turnover of cells. So it does, within 2 weeks, it should be filling in nicely.
And the way we do in this practice, we also give a palatal stent to protect that area.
Exactly.
Like an Invisalign tray.
We put a little bit of collagen tape as well. Just helps with the hemostasis. Now, the difference between the free gingival graft and the connective tissue graft, basically with the connective tissue or the free gingival graft, you are taking a whole piece of the palate there with the epithelium. So the whole piece, you just remove it with a little bit of connective tissue and then reattach it on a bed that was previously prepared. The connective tissue graft, basically you are taking the connective tissue layer without the epithelium. Mm-hmm. Exactly. Sometimes we take it as a whole free gingival graft and remove the epithelium outside the mouth. Sometimes inside the mouth we actually just make multiple incisions, remove the connective tissue and suture it.
But the thing is, it's the same tissue, right? It's the same tissue.
Exactly.
In one case we remove the top layer. In other cases we keep the top layer.
Exactly.
Yeah.
It's just basically
right.
about it depends on the indications, and we'll go
Where you put
into
it.
it exactly where
Right.
do we put it. Why are we doing this? Because with the connective tissue graft, it has to be covered by the tissue by the patient's flap. So if they have a little bit of keratinized tissue or maybe some form of vestibules that we can actually manipulate, that would be great. If they have high frenum attachment, no vestibule, then the best thing is just kind of create that new tissue with the keratinized with the freegital graft.
So anyway, we'll show examples. I hope
Absolutely,
it's
it
not
will
too
be a
confusing.
lot.
Oh, that's a good one.
This is
So this is connective tissue graft. So this is one where what you see here is a flap that's been formed around the tooth. You can see the tooth that had recession, and what you see on the second photograph is a little piece of connective tissue. That basically is harvested from the palate, but we remove the top layer. We only going to keep the connective tissue because we're going to cover it over, and then we cover it over with the patient's gums that we retained on the flap. Suture it, okay, and this is the before and this is the after. So we've gained thickness, we cover the recession 100%, and the area will blend in nicely in this particular case. As you see there, you can still see initially a little bit of the incision design. That will all go away over time. It just blends in very nicely. That's another type of indication. You see here there's no flaps. This is more of a tunneling approach where there's no incisions done, only between the sulcus and everything stacked in. The same graft is stacked in and sutured over. This is another one where you see the initial recession, and if you're, for those of you that are paying attention on the right photograph, you see a little bit of clefting too at the end of that recession. And after grafting, this is the early healing with the suture still in place, and then after it finally heals on the canines. So good healing in this particular case, complete recovery. Here's what I want to point out. This is not to show you, what a cool surgeons we are, or we can cover this. What I want you to point out is this recession was covered very simply because there wasn't any interproximal bone loss around the canine. The papillae are full. There's no gap there. The canine has all its mesial bone and all its distal bone. It's there. So as Dr. Aboosi said, if I were to, hang up that hammock, I can go as far as I want because I have very high tending posts for my tent. Okay, so and that's why we got full coverage here, and of course increasing thickness this way too. That's key. You want to talk about this case a little bit?
Absolutely. So I think this is actually our case, but this is the flossing cleft that Dr. Ntounis was talking about. And most times you see the patient actually when they floss, they go maybe from the distal and just kind of slips into the right there on the facial area. Usually they're just being overzealous with oral hygiene, and I'm sure a lot of you have seen videos online of using floss to cut watermelon or cake. So it can be really
watermelon hack watermelon with floss. This is a hack for the summer.
But it can be really traumatic in those areas. So, and this is actually can be particularly treated with connective tissue graft as it was done here. But the main thing is also we need to educate our patients whenever we see this, so that way
the mirror
it's from.
Put their mirror in front of them and say, floss for me. Exactly. And then they go all in there and they basically create that cut. Another little thing that you want to know about this. The good news, as Dr. Aboosi says, it can be treated. The bad news is most likely it needs a graft, because the way to find that out if it needs a graft or not is take your air water syringe and gently blow a little bit of air. And if you see the lips of that recession opening up a little bit, that means that needs a graft, because that's a cleft, that's a true open cleft. Okay, it's a complete cleft. And it needs to be, the way we treat those, we surgically excise the cleft even more, believe it or not, so we can get the margins nice and healthy again. We tack a graft under and we close everything, as you see. The suturing can be a little ugly looking, which you see that, but eventually it heals very, very well. But you have to almost make the floss bigger, the cleft bigger to treat those. If you don't see the cleft open up, it means you caught it on time. And what you could do then is take the floss away from the patient in that particular area. Utilize Broxy brushes and give them Q-tips with chlorhexidine, and they can swab on that area with chlorhexidine, and maybe give them the extra soft post-surgical brush that we were discussing from Tepe last time. It's a red brush, but take the floss away from them, and then reevaluate in about 4 to 6 weeks, 8 weeks to see what that area looks like. So that's a little tip for the flossing clefts. So that shows a connective tissue graft and how we do the tunneling. You see, this is, we don't have any vertical incisions. We go around the teeth.
It's minimally invasive.
Yeah, and we create a little pouch
Mm-hmm.
in there. This particular patient is under sedation, and so not that you need sedation to have that procedure done. They're just numb locally. And after we have a nice tunnel, then we can go ahead and utilize a little bit of connective tissue from the palate. You see I have the gauze on the inside because that's where I took it from. And I want to have a good pressure. And you place it nicely in there, and eventually that whole thing can be sutured properly and kind of go from there. All right, so you saw the connective tissue graft. In this particular one, it's get tucked in, and the top layer has been removed. Like what you feel with your tongue, that's not on the graft. That has been removed. Now, Dr. Aboosi will talk to you a little bit about this one.
Absolutely. So this is
Post-ortho, young patient.
and we see this actually pretty common, especially on the lower incisors here. Most likely, we are obviously when we see the root surface, we are missing buccal bone as well, and there's tissue recession in that area. And you can see where the tissue recession, the apical margin of it is almost in that mucosa that we talked about. So
it's in the mucosa, it's at the lip.
Exactly. So it's a Miller class 2 in this area. So if we think about it, if we're trying to do a connective tissue graft, we have to move all this tissue up from here, and there's really not much tissue in that area. It's very soft. It's all fragile, loose mucosa, so it's not very predictable to actually move the tissue. So the most predictable in this situation is actually to do a free gingival graft. So basically, you get the whole graft with the epithelium layer and attach it on the outside. Now, we may get full coverage in these cases, but because of the free gingival graft, we are putting it on an avascular surface, and there's no really flap to cover it. We're expecting partial coverage, but that is okay in this case because we are gaining that tissue. In a lot of cases, the patient wants it, because if we have interproximal bone is stable, we can always do a stage 2 approach for that. But first, we need to get a little bit of keratinized tissue that we can actually manipulate, because right now there's none.
Before you saw the final of this, I want to point out something, because the goal of this webinar is really for you to start seeing the cases through our eyes a little bit. So what you see in this patient? Well, number one, what you see is that the patient is almost edge to edge. That tells you that the orthodontics was a struggle for this particular patient. So the orthodontist had a hard time getting a class 1 occlusion, very simply because there's a lot of jaw issues. Maybe a very difficult orthodontic case, it looks like. Even without us being the orthodontist, we can tell by what they're trying to do here. The other thing that you see is overall, if you close your eyes on 24, 25, overall, the hygiene is not bad. It's fairly good hygiene here. The other thing that you see is on 25, on the left side, on the set on incisor, there's tremendous inflammation in that area. And the areas are red. And on 24, if you blow enough air with your air syringe, you're going to break through that tissue with just air, because there's nothing but a film, but a film of tissue. So these teeth don't have any bone in front of them. They're outside the bone completely. And one of them has broken through the gum tissue too. The other one is about to. Okay, so that as a kind of background of where we are. How that patient, I believe, was about, I want to say 13, 14, somewhere there. So this is the sutured free gingival. You were about to say how this is positioned, and I think there's value to that.
Exactly, and you can see, obviously there's nothing covering it, so basically the whole graft is left exposed because it has that epithelium. Now it will slough, and new epithelium will form in that area. Basically, where we want to place it in that area, you can't expect it to, place it too high up. We have to place it on a periosteal bed, we call it, just to get a little bit of that nutrients for the blood supply for the graft itself. Exactly, and it needs to have some thickness, 1 millimeter, to get a little bit of that connective tissue. Because if you just take the epithelium itself, it will not survive. And in the palate, the epithelium usually is 0.3 to 0.4. Yes. So we want to get a little bit, extra connective tissue in that area. And basically that's how it's stabilized in those areas, and this is how it heals. So in this case, we did get coverage. It's partial coverage. We can see a little bit of the root still exposed, but
which may not be there 5 years from there.
Exactly,
because it may all creep up and get the. But this is, I want to point. We should not expect this. This is a very good outcome, right? That's not always what we see.
Young patient, good oral hygiene. I think we have good healing in this case. But this is a very successful outcome. From where we were before to where we are now, we have preventing further recession in that area. We have modified the phenotype in this case. And,
you've increased the vestibular depth. The frenum is no longer there to create an issue, and the thickness has increased.
And it will be more comfortable for the patient to perform hygiene and fit a
So
toothbrush. Actually,
we can say that we did save 24, 25 forever, and that really makes us go to bed at night and feel good about ourselves, because that young patient now doesn't have to worry about their two front teeth on the lower. Let's pause and see what we've got here.
But just I think this way, or did I move?
You moved a little bit. Yeah, go.
Now this next case, pretty. It's not really similar to the previous case because this one is more generalized, but you can see.
But
going
not
back
a lot
to
of
the
recession
mucogingival,
here.
exactly.
Yeah.
But going back to that mucogingival junction and how much keratinized tissue and attached tissue we have, and if you can see here, there's really maybe 1 to less than 1, very minimal of that attached tissue.
You know,
see
where
the
that case
vestibule
referred. You know what that photo doesn't show? The frenum.
Okay.
And to see the frenum, you take the photo from the top of the patient. If you pull the lip out, take a straight photo, you don't always see the frenum. But here you can see how it's very close to the incisors.
Higher
and
attachment.
it's pulling, and every time it's pulling away the free gingival margin of 24,
which is very
25.
thin anyway to begin with and minimal.
Yeah.
So in this case, it would be an indication for us. Going back to that list of the goal, what do we need to achieve here? So really, there's not much root coverage to achieve here.
Sure.
But it's increasing that vestibular depth, increasing the thickness, the keratinized tissue, and just modifying that phenotype.
And removing that
and the frenum, exactly.
Thicken up that width, the zone.
This is how it's attached. It's left exposed, and this is with the healing. So you can see now we have more vestibular space. It's easier for the patient to clean.
No frenum there.
No frenum attachment there. Exactly. So that covers the autogenous
so
graft,
we can get some nice results with autogenous grafting.
Absolutely, absolutely.
Yeah.
Especially if it's limited areas.
Yes.
I think it's still the gold standard. This is what we
the analogy that I use for this is, it's like if you were to compare the autograft to the autogenous graft with the allograft. The autogenous graft is like it's like a house that has the HVAC, electrics, and already the plumbing already in it. All you get is plug it in the network. That's your tissue. Has everything.
Exactly. Microchannels.
The allograft is like these houses that you see, and you don't know about this. Maybe you do. I don't know. But they used to order houses from catalogs, and it would come in construction, and you put them together. Right?
Oh yeah.
So it's like
I
a
think
cell of a house.
It's called like a trailer. I think it's like you get delivered.
You get delivered. Yeah,
exactly.
It's like a cell of a house.
Exactly.
But they used to do that back. They had catalogs. You could order that house.
Nice.
I was there. No.
So autograft is great, but there's always some cases where either the patient is too scared to use their own tissue, they don't want to use their own tissue,
or we need just tons, and we have Miller class 1. We can get coverage.
Exactly. We have good keratinized tissue in some areas. So those are the cases that we can actually think of, okay, using allograft here. Obviously if the patient is okay with it. There are different types on the market. Basically the allograft is the acyl or dermal matrix. You might have heard Alloderm. It's from BioHorizon. There's also from LifeNet Health Oracell.
LifeNet Health, by the way, it's in Virginia Beach.
Yep,
local.
Exactly.
It's amazing tissue bank.
Exactly. So both of them are great. I think I want to say the Alloderm comes in gentamicin. I don't know about the oral cells are the same. So that's something just to be aware of. If a patient is allergic to it, really, that's the only thing. But overall, amazing tissue quality, thickness. They actually give you more than what you need. So it's really wonderful to use in indicated cases.
What are some indicated cases?
Exactly. So like we said, the adequate keratinized tissue. So we're just looking to get a little bit of root coverage. Patient already has good amount of tissue in that area to begin with. So for the allograft, it actually increases the root coverage, but also increases the gingival width as well. That is really important. I'll show you some of the cases of the pontics or around implants as well, thicken up the tissue. Healthy patient with good oral hygiene. The indication as well, no second surgical site. So like I said, if the patient has any reasons not to use the roof of the mouth, if they're really scared, then that's a great indication for that. Multiple sites. Obviously, there's only so much tissue we can get from the roof of the mouth in one sitting. So if the patient wants to do multiple sites, all the same visit, then allograft would be a great indication. And it's really great aesthetic results in those cases.
Yes.
So this is a case. It's actually with the flap. So we have a vertical.
I did that was 4 or 5 years ago. So I probably would not done the same today. But.
But you can see the tissue, the thickness of the tissue definitely looks a little different than the connective tissue graft. The patient's own tissue, it's a little thicker in that area. We stabilize it with sutures and then put the cover it. So with this allograft, same as connective tissue, think you have to cover that. It cannot be left exposed in that area. There are some allograft that you can leave them exposed, the xenogenic, but this one you have to actually cover. And you can see the before and after on that number 6. On
so the background of the allografts, and we didn't mention that, so it was not a dental thing, as always. It's something else. So it came out as a treatment for burn victims initially, right? Yeah. And they used to leave it exposed. They would put it on the burn, and they used to leave it exposed, and they had these terrible, sometimes supra infections. So we now know, especially in the oral environment, that's a very germ-heavy environment. You want to cover it, and we do prescribe antibiotics most of the time.
Absolutely, yeah, just as a prophylaxis. Yes. This is another case. You can see, I like the occlusal picture, the before and after. That is what we're talking about with the gingival thickness or the gingival width in that area. So you can see how this can be really wonderful in cases where if we have implants with very minimal buccal bone.
So this is a tooth, the canine's tooth, and the lateral is an implant there.
And we have recession on the canines also. This is kind of like
so it was a combined approach. And you may say, why did you want to thicken up the tissue around the implant? These are tough cases to do because tunneling around an implant becomes very technically sensitive. If you were to see that patient smile in a natural environment and they would just take their selfie, that area, because the tissue was thinner volume-wise,
see the metal.
It's dark. Yeah. It appears dark because the light has to travel more to get back to you, so it looks darker.
Yeah.
See? So, but if you were to add tissue, now it evens out with the adjacent teeth. The light reflects the same, travels the same distance, so it doesn't look back different in the human eye, and the smile looks more. There's nothing wrong with the implant. It's just a matter of very thin peri-implant tissue around it. So this was a very good indication for allograft, where you can cover the recession on the canine and also work on the implant at the same time and fix that aesthetic problem.
Exactly. This is another case of just, you see the before and after and the thickness of the tissue. You see how that concavity on the buccal, and now we have actually nice and natural, smooth transition.
That's again an implant.
An implant in that area.
Same problem, but in this particular case, you could actually see the implant through. And that lady had her implants placed a little bit too young, and what ended up happening is eventually the tissue is resorbed. Same problem. She had an implant lateral and another implant lateral. She would take a selfie. Great, everything would be great. High smile and beautiful woman. But at the same time, when she would smile, that would be an aesthetic concern to her. Graduations were coming up with her daughters and so on and so forth. So she said, I need something done. Well, we don't have a lot of good options here. We can either try to camouflage by adding tissue, or we can start over, get her implants out, do more grafting. Obviously, if you have two integrated implants, if they have buccal bone loss, we discuss the prognosis of those implants, but starting over is a tough call to make on a particular individual like that. So we decided to go with adding volume. Thankfully, we had some very, very extremely happy. What does that show?
So this is a video of the tunneling technique for the allograft. And you can see how we check passivity, make sure that it's all connected. That way when we place the allograft.
So the papilla are still attached, and we create a little tunnel.
Exactly.
Now, we need a graft that will go from one side all the way to the other. That's why alloderm in this case is a nice. Plus, you see there's no interproximal bone loss. The papilla are all there. So this is a great thick phenotype. You see. Thick phenotype of the existing gingiva. This is a great case after we finish the tunnel to tuck in an alloderm in there and make sure we
Halted
can...
with suture, coronally positioned.
That's
exactly. Right. This is a beautiful case by Dr. Ntounis, and you can see, before and after. So we do have interproximal bone loss, and that's what you can see, the dark, the black triangles there. So complete root coverage is not possible in this case, but still we can get partial coverage, and we are thickened. Exactly, we're changing the phenotype of the tissue.
And this patient was very, very well informed, and this is pre-orthodontics, because he wanted to do orthodontics and his dentist by the way, kudos to Dr. Preston Burns. Dr. Burns said this patient, hey, go get your gums taken care of before we start thinking about orthodontics. So not only can we not expect full root coverage because of the bone loss in the proximal, but also the orthodontic position prevents complete root coverage in this case.
Exactly.
So
this is the lower.
same guy,
arch.
same patient.
Same case. Yeah.
Yeah, same case.
This is just another case before and after.
See, the sutures are still there. That's
exactly.
3-4 weeks post.
This is another beautiful case. You can see the transition.
Would you talk a little bit about, if I were to go back, would you talk a little bit about the non-cervical, or are you going to talk a little bit about that?
We are, yes,
here,
yeah, absolutely. But as Dr. Ntounis was saying, if you look at number 11, you can see that little step. Some of you might call it abfraction. Some of you might call it noncervical or non-carious cervical lesion. Multiple. We'll talk about it later. The etiology, why it happens. But this is really important topic because a lot of times you see, the dentist would recommend, there's a class 5 restoration, let's put a filling in that case. But it's really very predictably treated with soft tissue.
I like to do it over and
over. It's very predictably treated with soft tissue, especially, so there are different kinds of non-carious cervical lesions. Some of them, if they involve enamel, yes, we will need restoration. But if it's basically on the root surface only, the restorative materials that we have, they don't really adhere very well predictably on the root surface, so they're always going to be leakage, and it just starts a vicious cycle of changing the filling restoration every couple of years. So this is a good indication that if you notice there's a carious cervical lesion, that fraction, but you can see still the CEJ or the whole crown is still intact, then I think it warrants a conversation about, hey, see a periodontist. And like I said, sometimes we still do restorative with it, and we actually prefer to have that done before we do the procedure, but I think it's good to have that combined approach taken care of.
So, yeah, and you will cover that, so I'm not going to...
Yes, exactly. There are different classifications and all that for that, absolutely. So, do you want to cover this, or do you the pre-orthodontic?
We briefly touched on pre-orthodontic augmentation. So,
and there is a best evidence article from the American Academy of Periodontology, and it just basically talks about changing the phenotype before orthodontic treatment. Is it indicated?
So before is the key here.
Exactly, and I don't want to bore you with a lot of details, but really the one of the main things in this article, the conclusion was bone phenotype modification should be pursued prior to orthodontic treatment in patients with thin phenotype when the necessary orthodontic treatment movement will compromise the bony housing. So like Dr. Ntounis said, expansive movement of orthodontic treatment. Similarly, soft tissue modification may be needed. So not only looking at the bone, but also the soft tissue. And I know we have an article that was published in the Clinical Advances of Periodontology by Dr. Ntounis and Pittman, and we'll go over that. There's actually a decision tree about them, which is pretty great to just kind of guide you through, looking at two components, really, the soft tissue and the hard tissue. So this is just a scan of a case.
Yes. So this scan actually shows you how this basically would qualify for what George Mandelaris calls in the previous classification that we showed thick thin, where you have thick top of the bone, but yet as we go further down, it's all fenestrated. Yeah. And if you were to move these teeth orthodontically, it would be helpful to consider adding bone, not just tissue in this particular case. So with what we call surgically facilitated orthodontics, you can not only increase the speed of orthodontics in an adult patient, which, by the way, that's not why we're doing surgically facilitated orthodontics. It's not the speed per se. It's to basically add bone and tissue and increase the envelope in which the orthodontist can move the teeth safely without causing recession. So by adding bone graft and tissue graft surgically, yes, you get the speed effect because you stimulate the bone, different discussion, different topic, but also you increase the envelope in which the teeth can move safely inside. That's the whole premise of that. And it takes a lot of grafting. That's what this photograph shows. This photograph shows that a lot of grafting in this particular situation. I believe this is George Mandelaris' case. It's very important to note that. which brings me to this case,
favorite
which
case.
is my favorite. So far we have told you a bunch of great successes, and life is good when we have successes, and we love successes, and thankfully most of our cases are successful, the great majority of them. There are some cases though that keep us up at night, right? And this is one of them. This is a 16-year-old boy that has presented to me post-orthodontics. And the concern and the referral was for me to cover this recession. This recession is not scary. It's a narrow recession. It's very deep. It usually responds very well, and I would probably treat that with a free gingival graft and maybe come back with a second stage and coronally advance if I need it. Well, I have attempted to cover this recession twice, and I have failed. That's never happened to fail twice in a site, and it's a very rare for me. So that keeps me up at night. It's a case that I take personally, and it bothers me. And I'm trying to figure out why this case is not responding to all our techniques and wonderful surgeries that we can do, as you saw in previous cases. And taking a 3D X-ray on this patient was very telling. So I want to show you what this case actually looks like. This is what this case looks like in a 3D model right here.
See the video on the
There is no bone whatsoever in any of these teeth, and particularly that one tooth that has receded, so the teeth are pushed out like this orthodontically. There is zero bone in any of these teeth. This is just tissue there, and that one tooth that doesn't get the recession, the bone, the apex is outside the bone, so it is extremely hard to get any type of coverage there. Very simply because there's nothing to support the tissue graft. And here's another video. Oh, so this actually shows this is what this individual's bone looks like. So this individual, look at this, went through orthodontics without a potential consideration of adding bone to that side. You may say, I'm not quite sure of the orthodontic story here. Could this be a jaw issue that was attempted to be corrected orthodontically, or does the patient have some kind of undiagnosed syndrome that basically predisposes them to have extremely thin bone around their teeth? But this is the bone that supports their teeth, and he's now 17. So probably this recession will not be covered, very simply because the bone anatomy doesn't allow me to do that. But I'm about to have a conversation with their parents about how risky this case is long-term, very simply because of the lack of alveolar housing for all these patients' teeth. These teeth are basically hanging by a thread. This is the bone and this is the tooth. And the tooth does this right here. So it's our personal opinion here at Synergy. And of course, we're not going to preach to anybody. But CBCTs have a role in modern pre-orthodontic analysis of cases. That doesn't seem to be shared with everybody, but that's our personal opinion because we do see cases like that. And when we have failures, it's important to identify why we're having these failures and why do some cases don't respond to traditional grafting techniques that have been working for 40 years now.
And actually, the literature support our decision. We have a best evidence consensus from the American Academy of Periodontology about the use of CBCT prior to orthodontic teeth movement. And really, the bottom line is that CBCT should be considered as a means to identify those at increased risk of developing dental alveolar bone deficiency related to orthodontic tooth movement, particularly in skeletally mature patient presenting with thin periodontal phenotype. So,
in other words, basically, if we were to translate that, we should take a CBCT if we're worried about somebody being in risk of recession before we
there's
do
a facial teeth
expansion.
I think that would be a great, just to be on the safe side, see what we have, and that would just prevent further complications like we saw with the previous case.
Yes. So this is a paper that's dear to our hearts because it's the first peer-reviewed paper that we published while in private practice Thankfully, we have published a lot of papers while we're in academia or in residency, but being running a private practice and publishing is rare, and it does require some time commitment. This is a paper we published with Dr. Pittman, and basically it discusses how we make decisions about augmenting, adding gum or soft tissue and bone graft for orthodontics that can be helped surgically. And the premise of this entire paper is rather simple. If we have an individual that has thick bone and thin gums, we can do surgically facilitated orthodontics just by adding tissue, soft tissue. If somebody is missing both bone and you're expanding, and also they have thin tissue, we should preemptively discuss about adding bone and soft tissue. And that is the case pretty much that was this particular individual that I showed you before. Other cases where we have thick tissue, but we have very thin bone and we're trying to do expensive orthodontics, that'll probably be benefited by just adding bone graft in these particular areas. Now, if we're talking about bigger expansions, and we're talking about teeth issues, again, this is not to treat skeletal issues. If somebody needs orthognathic surgery, they need orthognathic surgery. But if you're talking about expensive orthodontics that are aggressive, then we may consider just adding both bone and soft tissue preemptively. That's the entire premise of this article, right? And that comes through an experience of seeing cases like that and what's needed. So this is the case of surgically facilitated orthodontics. The lower incisors were very stubborn upon intrusion. The dentist wanted to intrude them to fit teeth properly to create restorative space. And we had to basically stimulate the bone, add a bunch of bone graft. And in this particular case, you also see an appliance that was used by the orthodontist asked to place in order to pull the teeth down and to intrude the teeth. And what you see is a layer of soft tissue covering the bone. So this is a combined case.
And this is allograft.
This is allograft, right? This is allograft. You're absolutely right. Where we do the bone graft and also adding the soft tissue as an extra layer. And if you want to have an idea about what this looks like, is you see the brackets have already been placed. The area has been grafted with bone, and this is how we're stabilizing layers of allograft to create more tissue thickness over the bone graft in this particular case. And of course, when we suture, you don't know what's underneath, everything looks normal, but for us, we've added a bunch of material because the orthodontist is trying to bring these teeth out. You see the lateral incisor there, they're trying to bring the teeth out, so he needs to do that safely. And in this case, faster too. But again, speed is the icing on the cake. We're not doing this for speed, we're doing it for safe orthodontic movement in high-risk cases. And that's another one. Talk a little bit about this.
So pre-prosthetic augmentation, we kind of touched base upon them before. Basically, if you have a pontic site that patient decide, I just want a bridge, I'm okay without an implant, that is great. But sometimes, after teeth extraction, obviously we lose volume of bone, and that what will cause is a little bit of tissue deficiency in that area. So what we can do actually in this case is a little bit of contour grafting. Not really hard tissue, it's mostly the soft tissue to make it a little bit more natural upon the pontic site in that area. Sometimes also, like we discussed earlier, if we have thin tissue and we're trying to do some gingival margin, sometimes in the anterior cases where it's more aesthetic, we have to have a little bit of thicker gums in that area, preferably attached keratinized tissue 2 millimeters to prevent recession in that area. So that is what we call pre-prosthetics, just kind of determining which patient are risk factor. And when in doubt, refer. If something's not needed, we'll definitely say it's not needed. But I think it's a good service for the patient to actually prevent further complications down the line, especially if they already had the restorative part done, because that will be a little bit harder to meet the expectations afterwards.
Yes, it's harder to cover an existing margin than
Exactly.
working around temporaries.
Exactly, working around temporaries, and then wherever the final margin is, then you can set your your final margin on
Should
top.
give kudos here to Dr. Jeff Day, because he's the one who recognized this particular case that needed this type of augmentation prior to his final preps, and that's what we did.
So this is the non-care cervical lesions. We touched upon them a little bit earlier. Basically, to patch or not to patch, do we want to fill them or not? And I kind of discussed it a little bit earlier. So first, they are common, up to 85%. A presence of noncervical cervical lesions. Most common on premolar and canines, maxillary or mandibular. Least common on incisor. Etiologic factor. It is a little bit controversial because before we used to say abfraction is due to occlusal forces, due to trauma or non-functional or a lot of
Parafunction, bruxism.
parafunctional. Excuse me. Thank you. Parafunctional habits. But nowadays, actually, we know it's multifactorial. It can be mechanical, it can be chemical, it can be due to toothpaste, abrasives in the toothpaste that can cause that. So that's why even really, we used to call them abfraction before. Now we're steering away from that because we don't know if it actually happened due to that, mechanical trauma that they used to say before. But anyways, we have to treat it either way, regardless of the etiology in these cases. How do we treat them? Do we do restorative, put class 5 composite, and call it a? Do we do grafting in that area? So the best thing really is to understand the anatomy of these lesions, and there's actually a really nice classification from Alan Winter 2011. It tells you first the depth, how deep that non-cervical carious lesion is, and also the extent of it. Is it in the root only in the cementum and dentin? Is it in the enamel only in the crown, or is it combined both? And the best way really to tell in these cases is to try to look for the CEJ. Maybe try to look for the contralateral or other teeth around and see where the CEJ is. How long is that premolar? And if you can say that, if you can see that the tooth is a little shorter, maybe there's loss of enamel as well.
Sure.
In addition to loss of root structure in that area. So after we actually determine the diagnosis and what do we have, which tissue is missing, then we can determine the treatment based on it. So we can do grafting only if first the gingival dimension is inadequate, and there's significant root exposure, and there's minimal to no enamel defect. So basically it's all in the root surface.
Yes.
Those cases, restorative treatment will not be predictable because, like I said, it will
Not only that, but it will condemn the tooth to eternal recession by putting composite where the gum needs to be.
Exactly.
So, that's what I like to say. Pink goes with pink, white goes with white. Don't put white on pink.
Exactly.
Leave it alone. We'll fix it.
Exactly.
Yeah.
Exactly. So those are the cases that if you see there's recession, exposed root, and then we have those cervical lesions, the best thing to do is actually gum graft in those cases.
Yes.
Now, some cases we might just do restore, and if if there's no recession, we have adequate amount of tissue and gingiva there, and it's really just the enamel is missing in that area, then that's yes, by all means, just restore it, and that's it. We don't need to, because soft tissue graft will not work on enamel. It's not going to attach there. It will recede, so there's no point in doing that. Now, some cases, and this is the most common, is the combination, where we have part of the root surface lost and part of the crown lost. And these cases, what we recommend is doing the combined approach, or first having the restorative dentist place the composite material. Try to put it as much as you can where you think the CEJ is, but sometimes it's a little hard, especially if you don't have a flap reflected. So what I tell usually my restorative colleagues is place the composite filling there. And when we have the flap and the surgical procedure, we can actually shape that to remove the excess composite that's on the root surface and make sure we create that nice anatomy in the CEJ, cementary enamel junction, and then we actually do the grafting in those.
Yeah, and if we don't want to talk ideal case scenario, and how Zucchelli treats it in Italy, the restorative doctor is there with the surgeon, and the surgeon is reflecting the flap. The restorative doctor does the restoration at the same time.
Because you have better visual in that, exactly.
And then the surgeon finishes right then and there, which is I don't know. In some practices that may be
feasible,
not so much in our situations.
Exactly, and this is just a couple of different cases of the just surgical treatment, combined treatment, and some just restorative treatment. Really, as you can see on the left side on that case. This is a really nice case.
This is a Zucchelli case.
This is a Zucchelli case.
Yeah, this is Zucchelli, where you
take the profile picture of those teeth, and you can see where it started on the left side all the way to the right.
But you see on B, the restoration has been placed with a flap. open. So the restoration is being done with the flap open, and then the flap closes on C, and D is the heal process.
Exactly.
It's phenomenal.
And
Work.
he argues that it closes a little better whenever we have the restorations there because it had to create a tighter seal in that area.
Yeah,
exactly.
it doesn't. What do you call it?
Slides back.
It doesn't slide back in
relapse,
the concavity. There's more volume to hold it in place.
Exactly.
So the blood clot is being formed more
inside.
More uniformly.
Exactly. More contained.
Yes.
In that area. This is a combined approach. Now, this was done where the graft was done before. It's still a sound treatment in this case, and the results are really wonderful because you can see we moved the gingival margin to where we think that the gingival margin should be and where the CEJ should be, and this is after the treatment. You can see on the top right where we still have some of those cervical lesions that were beautifully restored by the restorative dentist.
Yes.
And this is just, it looks more harmonious, just as how the tissue, we call it the dentogingival complex should look like. What patients should expect, this is just, if they ask questions, if they're being referred post-operatively, we usually prescribe pain medication. Really, ibuprofen should be sufficient in most cases. I don't think we need to go something stronger. Ice pack the first 24 hours. They might have some bruising, especially if they're fair skin. They might have some swelling, especially if you're using Allograft. They tend to have a little
more
bit
we
of swelling.
tunnel, the more we create that. Right? So
Exactly.
The larger the area, the more you're going to see of that.
Exactly. Antimicrobial rinse. I would say maybe a week, not 2 weeks. It depends really on the case as well.
We are moving away from chlorhexidine, or chlorhexidine is a great type of solution for ridge augmentation, sinus lifts, and so on. For our tissue grafts, we are slowly moving away from it. We're looking for other solutions. We now use a hydrogen peroxide 1.7% gel. It's called PeriRestore. Other antioxidant gels have been also suggested by Patal and other leaders in this field. So we're looking at more, natural type of solutions for post-op.
Exactly. No strenuous physical activity. Obviously, don't go running, 2 miles the next day, or do gardening or anything like that. Modified diets, soft diets. Nothing crunchy, nothing with seeds. No brushing for 2 weeks until the sutures are removed. That's why we're doing the antimicrobial.
A recent study published also showed that, that's a Tataki study, Ohio State, I believe, showed that if you remove sutures less than 10 days, that you may run the risk of
relapse,
rebound
exactly.
of the entire recession. So we leave them at least 2 weeks. Yeah.
Exactly. And then final evaluation at 2 months. And sometimes really it might take a little longer to actually for the gum settle, but usually at 2 months you should have a pretty solid idea of where we are and if any revision is needed. When to refer? Minimal or no attached gingiva, pre-prosthetic or ortho evaluation. If you're not sure, we're more than happy to provide our professional opinion. If there's a apparent frenum, a lot of pulling, or
if you have doubts on a very young patient.
Exactly. Progression of recession. If there's an area of recession the patient is not concerned about, you're not concerned about, but you've been monitoring it over time, you can actually see that this gum is receding more and more. That means this is something that needs to be addressed, because the earlier on it's caught and treated, the more predictable it is, as you saw with the cases, the more we actually have the gum creeping up. It's a little bit
it's
harder
important to say, don't watch it too long. I mean, if you identify it and you know it's there and so on, don't wait years until we refer it, and it gets difficult for us to treat predictably for your patient.
Root sensitivity, same thing. It would definitely help reduce, and it might eliminate completely, but we always try to set the expectations and tell them that there's no guarantee that it will completely eliminate, especially if it's something that is tooth related itself and not root.
Sometimes we get referrals for recession for sensitivity, yet we look at the tooth, there's no recession. Right?
Exactly.
We don't really have a good solution for that. Other than, of course, we'll start discussing about fluoride varnices, desensitizing, laser treatments, whatever.
Exactly. And if in doubt, if you are not sure, like I said, we'll be more than happy to provide our opinion. Trends, we kind of touched upon a little bit
Yes.
about, using the enamel matrix derivative, the EMDA gain, the platelet-derived growth factor, the GEM21 from Lynch Biologics, and other blood products. They can be used alone or in combination with some graft. We do use sometimes EMDA gain if it's a case that has some
hidden pocket.
Exactly, hidden
Yeah.
pockets, underneath or hidden recession.
Especially
then we can-
tangering cases on the lingual,
Exactly.
where you have this cleft in a pocket that goes with it. That's a good
Exactly.
indication
That's
for
a-
an EMDA gain. with
Exactly.
connective tissue.
It just gives it an additional layer
Yeah.
for the soft tissue to heal a little better.
Yes.
This is this is our favorite
Favorite
part.
Yes.
So we have before and after cases, and it's really nice just to see. The main thing is really looking at the goals, what we're trying to achieve here, and I think that's the best thing to say if this is a clinical success or failure. Because not all soft tissue treatment is about covering roots. Some of them, like I said, it's about creating more of that keratinized tissue or adding a little bit of thickness. So this is the first case. You can see on the lower right, number 19, number 30, and number 29. I believe the patient is missing number 28. So you see the before and after. There's recession that was covered. We have good results in these cases, and I believe it looks like there was some restorative treatment done on number 30 as well. So just kind of giving you a little time to look at it, but for me, this looks like a clinical success. We do have good root coverage there. Maybe not complete, but it's still good results, and we have created a good amount of tissue, keratinized tissue in that area if you compare before and after. This is another case, pre-op and post-op, and you can tell this is the free gingival graft because it was left exposed and created that thick tissue in that area. Same thing, we did actually achieve root coverage. It's partial, especially on number 25. You can see still part of the roots, but we have gained that thick tissue in that area, increased the vestibular depth.
That recession is not going to go anywhere.
Exactly. Same thing here, pre-op, post-op. So we can see those dark triangles between the teeth. So that tells us there's interproximal bone loss. So we should already know that we're not going for full root coverage in this case. But looking before and after, I like the post-op better because you see thicker gum. We do have partial root coverage in those areas.
But it is important. It's important that initial photograph, take it without the plaque in between, because if you have the plaque in between, it looks closed. But if you remove the plaque, you see there's black triangles between the teeth, and you're like, oh, you know what? Guess what? We're not getting 100% root coverage, and that's nothing to do with the surgeon or the surgical technique. It's more to do with the anatomy and the biology.
Exact biological limitations. This is another case. We have the PA from it as well. There's a little bit of, I would say, slight interproximal bone loss. But you can see on number 24, a free gingival graft was done. On number actually 27, connective tissue graft was done, and root coverage was achieved. Number 24, however, because we use the free gingival graft, our goal, and we do have actually another picture, I do apologize, it's not included, it was the frenum attachment in that case as well. So there's a lot of pulling from the muscle. So you can see in the before picture how red and thin the gum is, and in the after picture we actually have got that good thick tissue. And we did achieve partial root coverage. And we can always review, if the case or the patient needs a little bit of revision. Now that we have actually thick tissue, we can actually coronally advance it pretty predictably. Same thing here. The X-ray shows that there is bone loss interproximal. Number 24, same thing, had no attached tissue. It was very sensitive to the patient. You can see the root exposed there. Post-op, we did get
some root coverage.
Partial root coverage, exactly. Really pleased with how thick the tissue looks now. Like Dr. Ntounis said, this tissue is not going anywhere. So now that we actually did this, it will stabilize this recession.
That's a good case to also discuss. Occlusion also needs to be evaluated in this particular case. So if that tooth is high, it looks sticking out a little bit, and when they bite down, that's the first tooth that hits. That causes a lot of micro movement on that particular tooth. You can sense the mobility on that. But that's an indication to probably adjust the occlusion a little bit, occlusal refinement, let's call it, prior or before, during the surgery, but right before we place the graft. So that's important, the occlusion part of it.
Same thing for this case. I do apologize. The pre-op, it doesn't really show very well, but there was no attached tissue right on the mid radicular part, mid
Yes.
root part there. And you can see the after. We did not achieve complete recoverage. It was basically to create keratinized tissue in that area and thicken the tissue up. It is I believe it's called a periodontic, right, when it's in the middle. So it's an important tooth. It was very sensitive to the patient for brushing, so we wanted to make sure to give it a little bit of thicker tissue, more vestibular depth in that area. And that's pretty common in those premolar, lower premolars, that it becomes really very minimal attached tissue there. Another case.
So if you were to see the pre-op without the post-op, the question to ask is like, do I expect full root coverage or do I expect partial root coverage? And once you decide what you're expecting, is answer yourselves why. From what we said, why do we expect full root coverage or why do we expect partial root coverage? So in this particular case, we have what appears to be a buccally position tooth.
So that's Miller class 3.
That's a Miller class 3. Back to the slide with the classification. Miller class 3 classification provides
up to 70%
partial root coverage, right?
Mm-hmm.
So comparing and contrasting the before and after, in the before you have extremely thin buccal tissue. The type of tissue that is non-attached, it's completely elastic mucosa. And at the post-op, you have tissue that appears more coral pink versus red, less inflamed, and also thicker, as well as more attached. And the width of the keratinized tissue has also been increased. Also, some partial root coverage, a fair amount, I should say, has been covered. So this is a free gingival graft. This is where we take the entire graft and we just put it on it and leave it exposed. And this is what it does. It's safe to say that this particular little tiny bitty free gingival graft will save that patient's tooth for the rest of their life. So that's important. And if that person does orthodontics, then guess what? As you move the tooth back, suddenly your root coverage will become 100%. So that's important to mention. Yes. Again, same thing. Some buccal inclination potentially on this tooth. This would be an indication probably go back and try to
correlate
pull that thing up. Now that you created the tissue, right?
Exactly.
We created this, we have the tissue.
And I'm thinking there's probably also a frenum in that.
Sure.
It's just not pictured here. Absolutely. This is
elderly patient, obviously.
Miller class 3 to 4, Cairo class 4.
Yeah.
So there's definitely significant amount of proximal recession in that area. The teeth are splinted, so because of the amount of attachment loss, I'm thinking there's probably a little bit of mobility in that case. But that on the right side, you can just tell from that frenum attachment, the thin gum, it just looks very sensitive, and this starts a vicious cycle of just a patient not able to brush. Is very sensitive. You get more inflammation.
This will become a pocket. So probably you have a 4 or 5 millimeter pocket already there on the mesial of that tooth, and the post will probably have a 3 or a 3 maximum 4 pocket, and so on. Just by changing the quality of the tissue alone.
Exactly, and being a patient being able to perform oral hygiene a little bit more comfortably. Same thing. This is before and after.
Again, this teeth. Look at the teeth. Teeth are sticking up. They're sticking up, right? They're bringing all the roots up. The supra eruption of this particular teeth. This is your class 2 patient where the lower jaw is inside and they have all the room to go up over the time. And part of the recession is because of that. We should not expect full root coverage in this particular case due to the positioning of the teeth as they have supra erupted.
And this is
so pre-op and post-op. Should we expect full coverage here? No.
We have the interproximal bone loss.
That's it. So by definition, we shouldn't, right?
However,
that's pretty darn close. Yeah, that's pretty darn close. Yeah.
Pretty good. And you can tell the tissue difference between the pre-op and post-op. So this is a great clinical success here. This is also a great case, the before and after, and I like how you see the pre-op, the vascularity of the tissue, the mucosa, how thin it is, and compared to the post-op. Exactly, and the post-op, And this over time, really, you see how it's now narrow. Over time, this actually will have some creeping attachment, so
Sure.
we will get some more coverage up to 1 year, really.
Sure.
They keep growing in that area. Same thing here.
So this is all down to the mucosa. There's no attached tissue on the pre-picture, right? There is recession. Look at the oral hygiene of this patient. I bet you that had this patient had better oral hygiene, that creeping attachment would go all the way and cover the recession, because even at the top of the graft that you see on the picture on the right is still inflamed because of plaque accumulation. Plaque is a problem even after grafting. Okay, grafting doesn't take that problem away. People need to keep their teeth clean, and this particular individual obviously needs some help with that. So.
Another case. Obviously, you can see the interproximal bone loss,
Yes.
the amount of, and this is typical whenever we see narrow attached tissue, pretty sensitive to patient to brush. You see that.
So they're
plaque.
skipping that area, or they're trying to brush their teeth like this. Nobody does a little stepping up again and stepping down again. Nobody does that. So that area always accumulates plaque in that particular recession. That's my favorite. You want to cover it?
Absolutely. So this is the before and after. So you can see there's a little bit of amount of recession on number 24. Inflamed papilla is in between. There's the limited amount of keratinized tissue. But if you also look on number 23, 25, and 26, the length of those teeth, it does not look natural. There's no, they're short clinical crowns. So what happens is, and I believe this is a young patient, correct? So we have two forms of eruption. We have the active eruption when the tooth actually comes into the mouth. And then after that, we have actually the passive eruption where the gum recedes a little bit until the clinical CEJ to expose the crown. So in this case right here, it's a little bit of an illusion because you don't have the passive eruption there, so the gum is still up high in that area. So when you look at 24, you think there's recession. Maybe there's minimal recession, but not really that much.
The main problem of the tooth is the attached tissue. There's no attached tissue. That's the main problem of the tooth.
Exactly. And you can actually see in the post-op that the gum has, I think started to settle a little bit, to having a little bit of passive eruption. But 24, the way you are looking at it, it almost really has full coverage. It's just the way on the other teeth compared to
the teeth are not fully erupted yet. The other teeth, so you cannot compare a not fully erupted tooth with a tooth that needs root coverage and assume the difference is all root recession. It's not root exposed. Why is that? Why is that important? Well, here's the importance of it. When we do these cases, we will take the pre-op picture, put it in a big piece of paper, and print this out. And we will draw what we should expect as coverage for the patient. So imagine this: you're the mom. You bring in your 10 years old, 11.
Yeah, I think it's
right.
Teenage.
And say, all this is recession, and that's when we need to have a conversation saying, Mom, not all this is recession. Here's why: because the rest of the teeth haven't fully erupted, and as a result, you shouldn't expect that the gum on the teeth that needs intervention will grow all the way up there because it's not natural. The gum doesn't attach itself on enamel, right? So we will get it to where it needs to be, and eventually everything will blend in properly as the teeth continue to erupt. That is such an important conversation to have, because mom may assume that what you see as a post-op is a failure because you didn't cover the assumed recession. But in reality, the post-op is perfect success, although the gingival margins are not even. That's very simple because the teeth are continue to erupt. So the age of the patient, the circumstances are very, very important here when we set the expectations. All right. So not everything that you see on the pre-op is recession.
Another case, you can see the frenum attachment, the lack of keratinized tissue. Obviously, full coverage is not expected due to the interproximal bone loss. So if someone's just looking for root coverage, they'll say, oh, there's really not much that has been achieved.
Sure.
But looking at the quality of the tissue, you can see there's more vestibular depth, more keratinized tissue, and
Sure.
no frenum attachment in that area.
Thank you.
And that's pretty much
That's
it.
it.